This is a schematic representation of production of laser beam. In figure A, showing the flash lamp emitting a broad spectrum light containing xenon or krypton. It interacts with the holmium yak crystal, which excite the holmium ions to a higher energy level. These further emit the photons. These photons, reflected by the mirror at the end of the cavity, the reflected rays again interact with the holmium ion, which result in the excitation of further excitation of the holmium ions. And this cycle continues and again, resulting in the pumping. And at the end of the cavity, there is a transient opening which allows the laser beam to exit when desired. Holmium laser can be classified as a low power generator or high power generator depending on the generation of the power. The power generation low power generator can generate power up to the 30 watt, whereas high power can generate power up to the 120 watt. As the holmium laser contains the flash lamp, it generates a lot of heat, which require a cooling system. In high power generator, there are multiple cavities which contain the multiple flash lamp. It requires a vapor compression refrigeration system for its cooling. That makes it more bulky and less portable. KTP laser, also known as green light laser. It is derived from ND-YAG laser. It has a wavelength half of that ND-YAG laser, which is around 532 nanometer, and it has penetration depth around 0.8 mm. This laser is selectively absorbed by hemoglobin, but not by water. That's why it has a very good coagulation effect, which results in a good control of hemostasis. That's why it is more feasible in the patient which are on anticoagulant drugs. Its non-contact use called photoselective vaporization of tissue, most commonly used in the treatment of BPH. Thulium YAG laser. It is different from the thulium fiber laser because it is a continuous wave laser which has a wavelength of around 2013 nanometer. It is highly absorbed in water and low in hemoglobin. It has an optical penetration of around 0.4 micrometer, and its coagulation depth is less than 1 mm. It is highly absorbed in prostate, and it can cause tissue vaporization, but it is not suitable for enucleation. Thulium fiber laser. It is a valuable alternative to holmium laser lithotripsy. It has a long, thin silica fiber doped with thulium ion. It has a wavelength around 1914 nanometer. It can be operated in both continuous as well as pulse mode. This is the schematic diagram showing the thulium laser fiber. At the one end, it is having diode laser. And laser pumping is achieved by this diode laser, and this is a long thin silica fiber doped with thulium ion. And at the end, there is a transient opening which allows the laser beam to exit. The uniform laser beam at output connector allow the use of laser fiber as small as 50 micrometer. Thulium fiber laser core is around 10 to 20 micrometer and length is around 10 to 30 meter. It is electronic pulse shape modulation occur via diode laser. As it does not use flash lamp, therefore heat generation does not occur. Out of proportion, and water-based cooling system will not require a forced fan ventilation, the cooling mechanism in this type of laser. Here is the comparison between high watt holmium laser and thulium laser fiber. Thulium laser fiber can operate on the wide range of energy as well as wide range of frequency. The smallest fiber that is available for transmission of laser, thulium laser fiber, is 150 micrometer, whereas for high watt holmium laser it is around 200 micrometer. Small size fiber allow better maneuverability in the ECS system as well as inaccessible lower pole calculus. As well as it allows better irrigation and further better vision. The cooling system in the thulium laser fiber is fan-based, as there are no flash lamp is used, so heat is not produced out of proportion. Whereas in high watt holmium laser, water-based or vapor compression refrigeration system is required, as there are flash lamp which produce out of proportion heat, and as there is no mirror in the configuration of thulium laser fiber, its durability against shock is very high as compared to high watt holmium laser, which has a mirror at the end of its optical cavity. diode laser. The laser light is produced using light emitting diode. It has a wavelength around 808 to 980 nanometer. It is absorbed in water and behaves similar to anti-yak laser. It can be used for tissue coagulation and thermal treatment of solid organ, including the prostate. They are smaller, more efficient, and potentially cheaper than most other lasers now in use. Now coming to the application in endourology. For soft tissue incision, we can use holmium yak laser, ND yak laser, or KTP laser in conditions like urethral stricture, posterior urethral wall, endopilotomy, bladder neck contracture. For resection and ablation, like in BPH, transitional cell carcinoma, we can use ND yak laser, holmium yak laser, KTP yak, and semiconductor diode. For intracorporeal laser lithotripsy, there are only two lasers can be used: holmium yak and thulium laser. Starting with the application in urolithiasis. Intracorporeal laser lithotripsy is used in treatment of urinary calculus with retrograde ureteroscopy or either PCNL. A flexible quartz fiber delivers laser energy using flexible endoscope. Plasma formation occurs between the fiber tip and the calculus. This develops an acoustic shock wave which disrupts the stone along its fracture lines. Lithotripsy depends on the pulse energy and the diameter of the optical fiber. More the pulse energy, more the fragmentation occurs. And there are more chances of retropulsion of the stones. Whereas more the diameter, it can transmit more energy, but as the diameter increases, the flexibility of the scope decreases. Pulse energy ranges from 0.6 to 1.2 joule and pulse rate from 5 to 15 hertz. Most commonly, treatment for stone is started with settings of 0.6 joule and 6 hertz. Various techniques used for fragmenting the stone are painting, chipping, popcorning, and fragmentation. In painting, it is best suited for softer stone. In this technique, we move the laser fiber tip back and forth in medial-lateral or lateral-medial direction until a fine dust is achieved. It is more suitable for the soft stone. And in chipping, when the stone is hard, it is difficult to achieve a fine dust by the painting. So we held the stone steadily and fire the laser at the edge of the stone to achieve a chip of the stone which is less than 1 mm. This process can continue again and again until the whole stone fragment and small chips are fragmented off from the stone of approximately 1 mm, which can be later popcorned to the fine dust. And popcorning is best for the group of 3 to 4 mm in a non-dilated caliber. In this, we place the laser fiber near the stone but not in the contact with the urothelium, which deliver intermittent laser burst, which causes the movement of stone and fine fragmentation and help us to achieve the fine dust. Fragmentation is good for the best for the single hard stone. We target the center of the stone and fire a short burst of energy, which causes the stone to fracture along its natural cleavage line. We continue again and again to achieve the fragment of smaller size. Then by the process of popcorning, we achieve the fine dust. Comparison of Moses effect and Moses technology. In Moses technology, pulse energy is modulated in such a way that so there is a better target and laser interaction. First wave deliver energy to form a vapor bubble through which the second wave travel and target the stone. In this process, the less energy is lost and laser transmission is less dependent on the fiber stone disease. Hence, there is a minimum chance of retropulsion and more fragmentation. Uses of laser in BPH. The ND-yak laser, KTP, semiconductor diode, holmium yak, and thulium fiber have all been used to treat the BPH. The energy effect is determined by the wavelength of the laser light, power density, and duration of the treatment. Starting with the HOLAB. In HOLAB, the tissue vaporization can occur with the contact bare tip laser fiber. If gland is larger than 60 grams, enucleation is better. The prostate lobes are enucleated. All the both lateral lobe as well as medial lobe are enucleated into the bladder and further morcellated into the bladder and extracted. So it requires a morcellator, and HOLEP is now offered as a size-independent gold standard treatment for patients with lower urinary tract symptoms because of BPH. This is a video. This is a video showing the HOLEP procedure. In this, we make an incision at a 5 o'clock. 5 o'clock or 7 o'clock. In 7 o'clock, we place the incision proximal and lateral to the viromontana. The incision is deepened up to the capsule and circumferentially taken up to the 12 o'clock. The incision is taken circumferentially up to the 12 o'clock. The right lobe is enucleated. Right lobe is enucleated and pushed into the bladder. Similarly, the left lobe is enucleated along with the medial lobe. And HOLEP is appropriate for any patient who are on anticoagulant. It allows the concomitant treatment of bladder stone as well as urethral strictures. And in bladder, a morcellator is introduced and the tissues are morcellated. Now coming to the complication of HOLEP. The most common complication of HOLEP is retrograde ejaculation followed by capsular perforation and urinary incontinence. Urinary incontinence is transient in 10% patient, whereas it is permanent in 0.7% cases. Other complications are urethral stricture, bladder neck contracture, and injury to urethral orifice during resection or morcellation. Advantages of HOLEP are shorter hospital stay, lower early complication. Its efficacy is almost equivalent or nearly equivalent to standard URP, as only saline is used as an irrigation medium, so there is no risk of dilution hyponatremia in high risk patient and those on anticoagulant heparin aspirin. It can be used. It does not even require the post-operative catheter. Disadvantage: the tissue is not obtained for histopathological examination as it is morcellated. Use of laser can be utilized in malignancy. Urothelial malignancy can be utilized by two effects: photothermal and photodynamic effect. In photothermal effect, coagulation, necrosis of exophytic superficial bladder tumor up to 2.5 centimeter in size. In this photothermal effect, NDA laser is used, it limiting the energy to the 35 watt. The recently used laser in photothermal effect is thulium laser fiber. Whereas in photodynamic effect, tumor ablation is done in a manner in which a systematically administered compound is absorbed or retained preferentially by the cancer cell and converted by laser light to a toxic compound. The candidate for photodynamic therapy are patients with a superficial disease like stage TA, T1, and carcinoma in situ. Use of laser in urethral stricture. Urethral stricture may be post-traumatic, inflammatory, iatrogenic, or idiopathic. The laser used for internal urethrotomy include KTP, argon diode, NDA, and holmium laser. Laser used for BNI. Bladder neck contracture following prostatectomy has been treated using laser energy. Holmium YAG is the best form of laser energy for these cases because of its safety, precision, and minimal collateral damage. Posterior urethral wall fulguration. Posterior urethral wall is one of the most common cause of intravesical obstruction in male infant. The various therapeutic modality available for PUV includes electrocautery, fulguration, resection, and diversion. Fulguration can be done with holmium laser with low incidence of stricture formation.
Stop share. Stop share. Thank you, Dr. Mayank. So in the meantime, I would request my residents and faculty, if they have any query, please go ahead. And also the members who might have joined us today on Zoom link, I request them to give their suggestions or anything they want on lasers in urology to be highlighted. So few things that I probably noticed in this presentation. One was about the morcellated tissue which can be sent for histopathology. So it's not that you can't send tissue for histopathology if you're doing a HOLEP. When we used to do a vaporization of the prostate, like in green light laser or KTP, then there was no tissue available for histopathology. Secondly, the fiber you said is 150 minimum in thulium, which it can go to 50 mic, right? So that's the advantage of thulium fiber. It can go even down up to 50 micron fiber, whereas in holmium you have the maximum of 200, minimum of 200. So I'll just briefly summarize the lasers in urology. See, it is unthinkable in the modern urology department to be without lasers, because laser is has become indispensable for various urological procedures. It's not just HOLEP. HOLEP, we know, has become almost a gold standard for large prostates, and lithotripsy is almost, we would do lithotripsy by laser in most of the stones, so whether it is RIRS, URSL, or cystolithotripsy. So laser has become indispensable part of the armamentarium in urology department. And when we talk about just a brief thing about the lasers, we know the various types of lasers that we now use include thulium laser, holmium YAG laser, KTP laser, green light, that is, and diode laser. And I think these are the most common lasers which are being used in urology. ND-YAG laser is used for some kind of genital lesions or all those lesions. So we need to know the different varieties of how they are different from each other, because the lasers would be different because of their absorption by water and hemoglobin, their penetration, their wavelength, and there are other properties of coagulation, vaporization, etc. Because we know laser work by either coagulation, vaporization, or we can even make an incision with the laser. You, as residents, you must know all these things, because you always expect a question in theory on lasers in urology. And in practical also, you might be asked about the various settings to be used for lithotripsy, and how holmium YAG is different from the other types of laser that we used previously, right? Because previously we started with vaporization of the prostate and all those things, which is almost obsolete nowadays. I think besides, we know the two different important use of laser is HOLEP and lithotripsy. Besides that, as I said, you can make an incision starting from doing a a stricture urethra incision, doing a TOIP, PNI, even incising the posterior valve, incising the urethral seal, and then going up to the, if there is a ureteric stricture, you can incise the ureteric stricture, or you can do a endoscopic endopyelotomy, incision of the POJ stricture. So all these can be used with laser. Besides that, lasers are also being used, as we said, about in bladder tumors, not only for photodynamic therapy and etc., but you can do an en bloc resection of the bladder tumor excision with laser. All these are important because very few selected patients who would not do well with other kind of options, whereas this might help, because particularly patients who want anticoagulants. The chance of better hemostasis, less bleeding, definitely is an advantage with lasers. Though I was just in the AUA update meeting yesterday, there are newer oral anticoagulants available. These newer oral anticoagulants can be given till the last day, and you just have to omit the one night before the oral anticoagulant and in the morning, and then you can start the oral anticoagulants later. So don't have to stop for 5 to 7 days with the newer oral anticoagulants. So there are various other kind of advancements and which can be, I think we should all know about. So residents, do you have any query? Quick question. This is very disappointing that you don't have any kind of query in any. Okay. Dr. Dhamendra, you would like to say anything? Yeah. So if any of the faculty has anything to say, please put your video on, and so that we can see you, and you may ask a question. I have, I think Dr. Abhishek is there. Dr. Sahasdeep is okay, I think. So if nobody has any question, I would wrap up the session here. And thank you for joining us today, and have a good day.